Hi, good afternoon. We have no relevant disclosures, but we just want to acknowledge the Medtronic Minimally Invasive Therapies Group for supporting the data and actuarial analysis. There's proven clinical, financial, and societal benefits from laparoscopic colectomy. I don't think we have any questions about that. Despite this, laparoscopy is underutilized, with current rates estimated in approximately 50% of eligible cases. And in addition to the known benefits, this is an opportunity for surgeons to reduce their own costs by increasing the rate of minimally invasive surgery for colectomy, which can be a surgeon-controlled process measure. And this is necessary as we're in the midst of federal payment reforms in the United States, which are currently focused on patient-centered outcomes, like readmissions and complications, but are going to be moving towards value-based purchasing programs. The majority of us are in a traditional fee-for-service payment model, where insurers and patients pay each provider separately. With this, the quality measures are focused on hospitals. But while moving towards bundled payment systems, insurers and patients are going to pay one provider, who's then going to pay all other caregivers, and the quality measures are going to be moved to be focused on the physician. With these models, all caregivers have to be aligned for maximal efficiency, quality, and profitability. To ascertain the major drivers of efficiency in these models for colectomy, a full assessment of the risk-adjusted, short-term outcomes and costs is needed. So our goal was to evaluate the clinical and financial benefits of minimally invasive surgery from the payer's perspective to demonstrate the overall value of minimally invasive colectomy. And our working hypothesis was the reduction in complications and readmissions with MIS would result in an overall benefit to the entire healthcare system. To do this, we performed a review of the Truven market scan claims data for 2012 and 2013 elective inpatient colectomies. The commercial population included patients aged 18 to 64. To ensure that all patients were eligible for a laparoscopic procedure, we excluded metastatic cancer cases, emergent cases, and conversion cases. Cases were stratified by ICD-9 procedure codes into laparoscopic and open groups. Then groups were adjusted by demographics, comorbidity, risk score, and geographic region for comparability. Our main outcome measures were the average allowed costs, complications, and readmission rates. Since this is a sort of different view of costs and benefits, just some terms, the anchor is the colectomy inpatient admissions episode. Costs in this data were paid claims per reimbursement to the healthcare system, with the total allowed costs being all costs for the anchor episode and all costs in the 30 days post-discharge that were encountered, including facility and professional fees. And readmission average allowed costs per case were the cost of all readmissions spread across all cases, not the average cost of a single readmission, and this was capped at $100,000. Before risk adjustment, the mean age, risk score, proportion of patients with cancer, and case distribution across the 10 geographic regions was statistically significantly different across the MIS and open cohorts. During the inpatient hospital stay, the open group had a significantly higher rate of ICU utilization. The rates of overall complications per colectomy inpatient claim and colorectal specific complications were also significantly higher in the open colectomy group. The resulting length of stay was significantly longer open compared to MIS. After adjustment, the MIS cohort had significantly lower total average costs for the inpatient stay, including lower total facility and professional components for the anchor episode. Post-discharge, MIS cases also had significantly lower 30-day post-discharge costs. Overall, the total allowed costs, including the inpatient anchor episode and all associated 30-day costs post-discharge, were significantly lower with MIS than open, and the overall cost difference was $7,744 per patient. The open cohort also had a significantly higher readmission rate, 11.54 per 100 cases versus 8.28 per 100 cases, and a higher average cost for the readmission episode. So based on these results, we concluded that MIS for colectomy offered benefits for patients, payers, and providers. MIS had lower healthcare utilization, ICU stays, facility, and professional fees. And MIS resulted in greater quality through lower complications, readmissions, and shorter lengths of stay. Further, the allowed costs for the MIS colectomy episodes were significantly lower, almost $8,000 per patient. And this has great implications for us. With increasing bundled payment arrangements and accountable care sharing programs, the impact of shifting from open to minimally invasive surgery introduces an opportunity for cost savings and quality improvement. It's a process measure that we can implement to improve our quality of care and reduce healthcare costs. And it can also help surgeons so we can align the value of procedures better for appropriate reimbursement. Thank you.